Okay, MN is a 68-year-old white male at Bay Clinic Bohoa on 10/19/2011 to discuss his lab results. I will be soaping his hypokalemia. History of present illness includes low potassium levels dating back to 2003. MN's cardiologist prescribed potassium supplements and monitors him with EKGs and regular blood labs. Past medical history includes hypokalemia, genital warts, first-degree heart block, chronic hemangioma, coronary artery disease, hypertension, and hyperlipidemia. Past surgical history includes surgery for retinal detachment, coronary stents placed in 2003 and 2005, ganglion cyst removal in his left knee. Family history: father suffered from hepatitis and the mother suffered from colon blockage. Both parents are deceased. Social history: MN has a military background, non-overseas, for the last 33 years. He is married. He moved here with his wife from Iowa. Non-smoker, non-drinker, occasional caffeine, does light exercise, and recently started water aerobics with a low-fat diet. His immunization history is up to date. His review of systems: MN describes a dry, unproductive cough that does not bother him. He states that he is feeling well, aside from having low blood pressure recently, but feels better now that his medication dose was adjusted. Objective: the physical exam shows his vitals at height of 183 centimeters, weight 109 kilograms, blood pressure 119/73, heart rate 61, ideal body weight 78 kilograms, serum creatinine of 1, creatinine clearance of 78 mils per minute. MN appears well-nourished, alert, oriented to person, place, and time, no physical limitations, no physical assists. Relevant lab values from 10/14/2011 show potassium levels at 3.8. All other electrolytes, lipid levels, blood glucose levels, liver panels, and kidney panels are within normal range. MN has no known allergies. Current medications include potassium gluconate, 595 milligram by mouth, 2 times daily for hypokalemia. This provides him 5 millimoles of potassium daily. Aspirin, 81 milligrams for antiplatelet action. Valtrex for genital warts as needed. Metoprolol tartrate for hypertension. Lisinopril for hypertension. Lipitor for hyperlipidemia. Fortify multivitamin for eye function. Fish oil for high triglycerides. Risk factors. The National Council on Potassium in Clinical Practice guidelines state the following possible causes of hypokalemia: inadequate dietary intake, diuretics, high sodium diet, hypomagnesia, prolonged diarrhea or vomiting, aldosteronism, Cushing's disease, large doses of corticosteroid, Little syndrome, Bartter syndrome, urinary loss in congestive heart failure, catecholamines, insulin, antibiotics. For MN, it was not made clear by the patient or his charts the specific cause of his low potassium, but it was prescribed by his cardiologist and described by MN as being for his heart block, a preventative measure. Framingham risk score is over 20%, and this translates to a vascular age of over 80 years old. Hypokalemia in this patient must be treated because of his history of heart block. The National Council's guidelines state that the purpose of this is to reduce the risk of life-threatening cardiac arrhythmias. They also state that for patients with arrhythmia history, levels should be kept over 4.0 millimoles per liter compared to the expected value of 3.5 for normal individuals. Potassium gluconate is appropriate for this patient. Guidelines suggest all forms of potassium except potassium bicarbonate, which should be only used for those metabolic acidosis. The dose of 595 milligrams twice daily, providing a total daily dose of 5 millimoles potassium, is below the recommended dose of 20 millimoles per liter daily for hypokalemia prevention. MN's potassium levels have recently dropped to below 4, so this dose is not currently appropriate. Guidelines also state that potassium should be administered at the same time with magnesium to increase the uptake of K. The oral route is appropriate as MN does not have any problems swallowing pills. The interval frequency is appropriate as potassium gluconate can be dosed once or twice daily. Signs or symptoms of adverse effects: MN does not have elevated potassium or GI tract erosions. This is the only drug prescribed for his low potassium levels. Therapeutic alternatives include 3 different potassium salts: potassium bicarb, potassium phosphate, and potassium chloride. Potassium bicarbonate, this is not an appropriate alternative for therapeutic indication. And for potential interactions, there are potential interactions between potassium supplements and lisinopril, which is an ACE inhibitor that are known to increase potassium levels. Recommendations. So since MN is currently not at goal levels of over 4 millimoles per liter, I recommend first to maintain the current dose of potassium gluconate, which is the 595 milligrams twice per day, total daily dose of 5 millimoles per liter. Additionally, I recommend following the guidelines and adding magnesium. They do not offer an appropriate starting dose, but Facts Comparisons does state that dosing can start at 240 milligrams per day in divided doses and can be increased as needed. Magnesium is available as elemental magnesium in 100 milligram increments, so I would suggest starting him on 200 milligrams daily, divided into 2 doses to start, and they can be increased as needed. The following drugs can worsen hypokalemia and should therefore be avoided: diuretics, corticosteroids, catecholamines, insulin, and antibiotics. No tests are required to provide missing patient information. For monitoring and goals, guidelines state that the goal level for patients who have experienced arrhythmias or heart block should maintain potassium levels over 4 millimoles per liter. This patient requires close monitoring of potassium, not only due to his history of heart block, but also because of his use of ACE inhibitors, which can increase potassium. The acceptable range for potassium is very narrow, between 4 and 5, and should be monitored more frequently until his potassium levels reach 4. Additionally, NMEN should continue EKG monitoring with his cardiologist to watch for the physiological effects of hypokalemia on his heart. Drug-related side effects to monitor: hyperkalemia, which can be monitored with blood tests for electrolyte levels. Additionally, the patient can monitor for GI irritation, including nausea, vomiting, diarrhea, and gas from the K, or cramping and diarrhea from the magnesium. Patient education. And then, your potassium levels were a little lower than we'd like to see. You are at 3.6, and we need to get your potassium up to 4.0 millimoles per liter. It's important to discuss these lab results with your cardiologist. You will be continuing your potassium supplements as you have been, which is taking the 595 milligrams potassium gluconate twice per day by mouth. Since these can cause stomach problems, try taking them after meals or with food and with a full glass of water. Make sure you do not chew or crush these, only swallow them whole. It is very important to take your medicine routinely so that your potassium levels do not go too high or do not go too low. If you miss a dose, and that dose is within 2 hours, take it as soon as you remember. If it has been more than 2 hours since the time